Good morning. Perhaps for those who are already here, good morning, everybody. Buongiorno. We want to wait until 9:30 because there are some colleagues which are still coming to the room, but also coming online to the meeting. So I think we should stick to our schedule so that you are informed. Yeah, we have to wait another 10 minutes. Rosa made this wonderful proposal that when, if there is some need or wish, desire to speak, we can start with it until 9:30. Perhaps just, is there any wish, question, comment which we can share already before we start officially?
Yes, my name is Paul, and I'm a philosopher, no connection to therapy. I would ask you a question regarding Freud, drawing a parallel to Wittgenstein. They both were writing in German language. Wittgenstein, however, was a Cambridge man, studied in Cambridge, became professor in Cambridge. So what he was writing, actually, he was translating in his mind from English language into German. And I've seen quite a few people who don't understand him very well after reading him in German language only. And Sigmund Freud was actually opposite. He was writing in German language, and afterwards the translations are getting in my mind, maybe it is in my mind only. And that's my question. How would you describe a difference, what you can feel actually by reading his works in German language and interpretation in English? Like Gottlob Frege said once, there is a sense and there is a reference. Once we have a word, then we draw parallels, we draw connections into context, and that is, in my mind, it is slightly puzzling. Thank you.
I personally could answer to this, but I will try, but I want to ask, is there an answer from you?
Nobody speaks German.
So perhaps I can start as a German, and then yeah, thank you very much. Thank you very much, because this you touch on a very crucial point. Reading Freud in German for me, and I think for our German colleagues who are here too, is in a way different from reading it in a standard edition, because there are sometimes very strange translations. And I agree, I just cite Wittgenstein. Wittgenstein has said, the limits of my language are the limits of my world. Yeah? So this, and in a way, it's true, language and also translations. And we as psychoanalysts, we are in a way translators. In a way, other forms of translators, not only just from one language to another language, but also to psychic languages. But I want to say there are some strange translations. For instance, I take the term Besetzung, the German term Besetzung, which is translated in English with catexis. This is a very strange translation. Nobody understands it really. What does it mean, catexis? It's a Greek term. And so, but you know that Mark Solms has just edited and published a new translation. And I'm very eager, and I think a lot of us, and all of us, are very eager to read the new translation. Has been necessary, and I think that there are some other terms also. And whenever I write a paper in English, I go to the original German version of Freud, and I go to the PEP web and you can read the standard edition, but very often I have the feeling, oh, is this what Freud said? So you are right, but we can only improve. Now, nevertheless, I think we have to respect the enormous amount of work of the initial translation. I think this was excellent work. Nevertheless, there are some misunderstandings. But it's a work in progress, I think, and psychoanalysis also has to be just developed also in the realm of language. This is but perhaps somebody of German, Misha or Gerion. Oh.
Thank you. I started reading the article of Mark Solms about drive, and there he explains it very nicely, and he hits the point how to translate. And I have been in a working group, French-German working group, and there we tried to find out how La Blanche translated, and it was excellent too. But I must say in the English translation there are some unclear expressions.
As I like to connect it to our theme, altered states of mind. I remember 4 years ago I made the reading meditation with Traumdeutung, dream interpretation. And usually if we are in seminars, we are used to read very, very quick. And so I discovered in my Hängematte, Hummingback, you know what I mean? Just between two trees, I just started to read like music, the Freudian text, and very slow because there was no pressure at all to read it. So I would say even you can read Freud in original language like a melody. You can start to become realize altered states of mind if you are slow reading Freud, and it opens the doors to perception. I guess also to refer to the medical issues, when I studied medicine, I was used to read 100 or 100 pages a day. That's completely destroying the feeling of the words. So just to use this moment in combination with altered states of mind, I recommend everyone here in the room to start to read slowly and discover the music between the lines. Not depending if it's Italian language or Greek or whatever. Enjoy.
Yeah, thank you very much. Perhaps I can add only one sentence, just because reading Freud in German for Germans is a pleasure. Also, what Misha said, because he has a really, I would think, a wonderful language. And you know that he has been awarded also with the award for scientific poesy. So he was not only a scientist who wrote dry scientific papers, but his language is really a pleasure to read and to receive and to enjoy in a way. Yeah? So and sometimes this is also, to my mind, not so easy to translate into other languages. So. Okay, thank you for this question and comment. That's very helpful. I think now we can start with our official program. Am I right? Yeah? Okay. Then again, I want to welcome everybody here on the table, everybody here in the room, and due to very dense time, I think we should start. And we will start with our colleague Sergio Anastasia. And Sergio Anastasia is a psychologist, psychotherapist, and psychoanalyst. He's an associate member of the Italian Analytical Society and the IPA, and I just learned that you are traveling from north to south in Italy. Yeah. He works between Milan and Puglia. So please, and you will give us a clinical case. Yeah, thank you very much, Sergio, for this good clinical example, which gives just stimulus to discuss. And thank you also for keeping the time. And I think we switch immediately to our round table, because there is a lot to say about this. And I think we will start in this direction, and we'll start with our colleague Alessandro Bruni. Perhaps you can also put the biography here on the screen. Alessandro Bruni is in the beginning biologist, and he gave his dissertation thesis in the Rome University on LSD and altered states of consciousness with the Nobel Prize Daniel Beauvais. And he has been working in private practice in psychoanalysis in groups since 1980. And now he is training and supervising analyst of the Italian Psychoanalytical Society, and also founding member and training analyst of the Italian Institute of Group Psychoanalysis, and member of Synaptica, a mind-body research center, and supervisor along health services in many Italian cities. And now I'll give the word to you that you can give your comment. Everybody of the discussants will talk about 10 minutes, yeah? So that you are informed. Alessandro, please.
Thank you, Heribert. Before commenting on the clinical case brought by the colleague Anastasia, I would like to recall some characteristics of the psychedelic experience, in particular of that induced by LSD, which make it highly dependent on the set and setting in which it occurs. The effect of the drug produces a decrease in rigidity of the entire psychic system, a loosening of the usual beliefs of recognizability of the world, a strong increase in plasticity, mobility, and dependence on the context in which the experience takes place. If one is near a person with whom one has a significant relationship, the situation is configured as an attractor that accentuates and deforms all the projective and introjective mechanisms usually used. In psychoanalytic terms, different effects are produced in the relationship with the world. First, an increase in the intensity and quality of the processes of transference, rigid motion transference of Freud, and of projective and introjective identification, projective transformation of Melanie Klein, processes that can be further accompanied by concrete visualization of an hallucinatory type, transformation into hallucinosis of Bion. Second, hallucinatory construction of bizarre objects, that is, in the sense of Bion, of real objects that undergo a perceptual or semantic deformation as they are used to evacuate objects, thoughts, or split parts of the psychic apparatus or personality. Third, intensification of paranoid experiences as a result of the intense projection of persecutory superego aspects. Fourth, but also experiences that can be inscribed in a relational, evolutionary parametanoia circuit. I mean that an initial paranoia, that is a psychic protrusion that becomes a mind out of place. This is the original Greek meaning, so paranoia is a side mind outside its place, is followed by a metanoia, conversion, evolutionary transformation, by which the mind returns to its place transformed. It is a more general abstraction from the relationship that originates at the beginning of the life between the action of projective identification of the newborn and the answer or reverie of the mother. Last, but finally, even the possibility of transformation in awe, that is closeness to becoming the unknowable reality, which ancient Greeks used to call physis, the hidden nature of things. For the discussion that interests us about Giorgio's case, it is evident that the presence or absence of an important person, such as the analyst, is a discriminating factor on the quality and outcome of a psychedelic experience. We are talking about a patient who experiences the use of substances in his private life, outside the analytic room. We can ask ourselves in what relation these experiences are placed with respect to the analytical work with the analyst. In the first instance, it seems that this separate use offers the patient some relief from his obsessive and contradictory conflicts and opposed to his sort of borderline aspects. On the other hand, he seems unable to entrust his psychic situation completely to the analyst. That is, he cannot lose an idea of total control over his inner world, agitated by paradoxical conflicts. Furthermore, he seems to fear that his productions may affect the transference relationship, with the risk of evacuating on the analyst also his aggressive drives, and thus destroying the relationship itself. In this sense, the use of substances may have acquired the further meaning of protecting the analytic bond, which in other respect it is itself the object of attacks. For this reason, perhaps, the patient never thought of coming to the session under the effect of a drug, or asking the analyst. Sometimes happens that patient arrive like, "Oh, doctor, I smoke a joint." Okay, I say, "Hey, what tell me what and or asking the analyst to activate in a specific setting the possibility of having a shared experience. Apparently, he uses drugs, but also alcohol, as palliatives to evacuate an excess of dangerous and painful stimuli, just as a gym fanatic needs to train 2 or 3 hours a day to avoid entering a maniac depressive state and to avoid becoming violent, with his wife sometimes. No? These evacuations seem to allow Giorgio to glimpse a higher metavision, freer from the shackles of his borderline behavior, but they seem to have only a temporary effect. Through the information on the characteristic of his relationship with his parents, it seemed that Giorgio was not able to go through the Oedipal dimension, understood mainly as a challenge for his individuation, and that he remained at the mercy of very violent emotions and impulses of a pre-Oedipal type, such as suffocations and homicidal rages. I wonder if we can also hypothesize that he suffered and repressed an early trauma, since he seems like a person who carries an unexploded mind inside himself. It is difficult for me to say more. We could do an exercise of imagination and try to think about what we would face if it were possible to agree on a psychedelic experience together with the analyst. An experience of this kind in this specific analysis could be challenging and require caution. In fact, if the patient agreed to insert in the course of some analytic sessions doses of hallucinogens, there would be the problem of facing the kind of oscillation and paradoxes that are described by Wilfred Bion in the book Second Thoughts, pertaining to the transference of the psychotic part of the personality. It is a matter of making present the primitive monsters, the disastrous couple of his internal parents, antisexual and castrating, whose projection would invest the analyst in an hallucinatory way. The analyst could become an intrusive, a suffocating presence, a mother who wants to take the patient back into her belly, or impersonate a threatening paternal superego, ready to accuse and punish Giorgio for his homicidal desires. The challenge in this special analytical situation is to be able to protect the relationship and strive for catharsis, that is, for a diffusing of the encysted nuclei. In short, the work of bomb disposal experts. Thank you.
Yeah, thank you very much for your thoughts. And we will go immediately to Dr. Johnny Martell. I don't have to introduce him again. You know him just from yesterday.
Thank you very much. That was a beautiful case and very interesting comments. I think for me, I found the description of Giorgio on the Rock a very poignant and moving portrayal of what maybe seems to be starting to happen, even in brief moments, where there's a bit of a resolution of opposites and various polarities within himself. A very moving moment. I had a vision of him experiencing both there was something about him experiencing himself both as a subject and an object of the experience of isolation, of rejection, and that felt, really very moving. But yeah, for me, there was something in these, I think he used the word glimpses. They're short-lived, but he's having little experiences of a greater fluidity, greater integration of what's clearly a very divided, split character structure. I was also very grateful for this case because just bringing it back to kind of, I suppose, my area of experience in clinical trials, I don't think we think enough about the demand that's put on us in sessions, maybe on an hourly basis. There's an expectation that the language is to check in with participants to see how they're doing. And it could be a very sort of crude check-in to somehow measure the intensity of their drug experience. But I don't think we reflect enough on how incredibly intrusive that can be when you point to the danger, or when we think about the danger of however he experienced his mother intruding upon his experience. So yeah, that was very helpful just to reflect on that. Alessandro, I found your, invitation to imagine what it might be like to do some work with him, a very kind of enticing invitation. Myself not being experienced working psychoanalytically, I think I recoiled from the idea of it. Your language of the work of a bomb disposal expert really kind of rang true for me. I was thinking if psychedelics can increase the transference neurosis, the transference anxiety, in this case, given how split Giorgio seems to remain, that feels potentially quite explosive. But yeah, I'm coming from a place of working clinical trials, not doing long analytic work, but a really interesting thought experiment there. Yeah, I think those are my main reflections. But yeah, thank you again.
Yeah, thank you very much. And we can just switch to Chiara Rogora. Chiara Rogora is a psychologist, psychoanalyst for children and adolescents. She's a full member and training analyst of IPR and International Association for Analytical Psychology. She is head of psychologist. Oh, now I have to TSMREE RSL RM2. I don't know.
Analytical Association.
No, but
IPAN.
TSMREE RSL RM2. You have to explain it by yourself. So it's she is working in the health public service. I think this is important with children and adolescents since several decades, and she has dealt with early relationship and early relational trauma. In particular, she deals with psychopathology of adolescents and has also published several scientific contributions in journals and books. But the TSMRESL, I'm sorry, you have to explain by yourself.
Don't worry. Thanks. Thank you very much. I thank you for this invitation. I would like to start by saying that commenting on a case that my colleague has generously offered for our reflection is always a complex matter. Okay. It is necessary to declare what plans it will address, or that each clinical case is unique and that the analyst-patient diet at work is equally unique. Having said this, the case is a starting point, and only the protagonist of the story can know how things really went. First of all, I observe the proposed case based on my experience as an analyst and therapist who deals with childhood and adolescents in a public service. This personal bias of mine made me focus my attention on the adolescent period of Giorgio, who is not mentioned, but the words that represent his childhood are a state of isolation and rejection. A mother who is depressed and withdrawn into herself, and a father who is incompatible with him, distant and hypercritical. Who was Giorgio, and how did he feel as a teenager when he landed the some island of identity? Can I imagine a boy struck by strong emotion and unable to contain himself, subjected to bouts of emotional dysregulation, perhaps with hetero and or self-aggressive aspects? The belief that he is healed with the brain cancer seems like a self-destructive fantasy that in today's teenager would perhaps have taken the form of self-cutting. How did the lockdown affect that anguish that brought 30-year-old Giorgio to therapy with a profound sense of helplessness and confusion? Giorgio, he seems to have touched the deadly shadow of maternal depression, and like a desperate adolescent, he casts this shadow on the therapy, or rather on the therapist, who must support a negative transference and work with negative, primitive, depressive emotions. Giorgio seems to deposit parts of himself, some more adaptive and functional in the external environment and work, other more distressing and deadly in the therapeutic space, or vice versa, once again in research of functional regulation. From enfant prodige to enfant handicapé. Between Scilla and Cariddi, Giorgio struggles between the opposite of a fragmented self. Giorgio and the substances, it seems to refer to an attempt at self-care, self-regulation, of dysregulated and fragmenting emotional states. Adolescents are pushed in an era of particular fragility to resort to substances with this underlying self-healing drive. Many studies have highlighted how early relational traumas constitute a field of fragility where the use of substances is a behavioral modality to be resorted to under stress self-therapy when the self is destroyed by sensation or emotions that cannot be symbolized and cannot be tolerated. The use of the substances is a self-included dissociative state with the aim to establishing a different psychosensory parallel reality, withdrawing from contact with sensation, emotion, conflicting, imaging that cannot be represented on the level of consciousness. Or, as Alcar and Panksepp recall, quoting Bayons, and though they argue the most archaic psyche phenomena generate in a no man's land before a clear distinction between subject and object as being considered. These are effects and fluid imagine where the self does not hit its precise boundary and expand in the form of a flexibility expanded with despaired conscious sensitivity. At this point, the method of approach seems important rather than the substance. From what this report from colleague Giorgio seems to experience another world that puts him in contact with sensations and emotions of connection, universal, collective, profound themes, but which require someone to embody them. The movie Avatar comes to mind, where the protagonist, suffering from a motor handicap, experiences a world where he discovers primary emotion and connection with Mother Earth, nature, relationship with the opposite sex, through an avatar who can move freely. However, upon returning to the ranks of consciousness and everyday life, the daily challenges, who can Giorgio benefit or integrate the experience that his avatar has had? As my colleague Sergio highlights, it is difficult to understand the role of the hallucinogen substance in particular and the weight of this may have had on the therapeutic relationship. In fact, it seems that the patient who indulged in a polymorphous use of substances was able to benefit from the therapeutic relationships that was able to hold the rudder of the boat under the storm of negative transference, was able to contain emotion and thoughts that Giorgio was able to evacuate into analytical space. A test very hard, but perhaps one of the most important therapeutic factors for patients with early traumatic deficiency experience and consequent personality disorder. Here, the therapeutic relationships comes into play, which is perhaps the connection between the avatar world and the current world, which allows a restitution of the experience and the integration of part of oneself, the return ticket. But what does the therapist do? Often with adolescent traumatized patient, it is a listening witness with the sense highly trained to perceive, feel what the patient feels in order to report in the form of a possible representation, ready to capture and hold. I believe that each patient needs a tailor-made suit that always includes the substance and their effect. With teenagers, you learn something new every day, also about what is constantly moving and changing on the drug dealers and on the dark web. However, returning to Giorgio, what makes the difference between an experience with substance and in a self-care framework, and an experience at the second, I can be sure, narrated, integrated, is supported by the relationship with the therapist or by relationship with the group, as happened, for example, in shamanic healing rite. Sometimes my young patient look at me with a challenging air and say, "You can understand if you haven't tried these things," referring to experience with the most disparate substances. I reply that it's not this essential, and that they can show me, and we live together. Start of loneliness and isolation and notable relation difficulties often emerge. The substances in some cases risk being a journey of no return. In conclusion, in this clinical case, the therapeutic relationship cured the integration of the self part. Starting from the concept of the emerging self, we are legitimate to thinking on a social self connected at various levels. The self and this characteristic self-relatedness seem to be constituted in relation to other self and therefore as the result of the differentiation or distinction. Okay.
Yeah, thank you very much also for your comments on this interesting case. And now we go to the other side of the table.
Thank you.
Jeffrey Guss, you know him already, so please.
Thank you. Thank you so much for this extremely intriguing and complex discussion about a patient and his treatment and his use of psychedelic drugs. Rather than focus on the interior world of the patient, I'm going to focus more on the relationship between the patient and his analyst and the countertransference processes that might be active in contributing to the formulations that have come about in understanding him. First, I want to say that this patient is not in psychedelic psychoanalytic treatment. This patient is in psychoanalysis with an analyst who does not have facility, knowledge, or trust in the psychedelic process. And this position itself, I think, affects the entire course of the discussion of what is going on with this patient in this particular treatment. In fact, I'd like to share a rather clever phrase. This psychedelic use occurred apart from the treatment rather than as a part of the treatment. And I think that that has a tremendous amount to do with how he's formulated, how the experiences are formulated, and the questions that were raised. The second takes us into a different realm, which pulls away from psychoanalysis and says this is somebody who has a history of alcohol abuse and polysubstance abuse, and perhaps the treatment might be reconsidered to move toward addiction treatment rather than psychoanalytic treatment as a way to help this patient if indeed he has an alcohol abuse problem or a polysubstance use problem. But moving from that, what failed to occur is an exploration in the transference and in the countertransference of the meaning of this patient's use of psychedelics and other substances, and a bringing forward of the experiences that he had into the transference, in the sense of the countertransference suspicion of the experiences as solipsistic and self-medication and apart from the analysis, instead of there being seen as something happening outside of school, they should have been brought into the experience and interpreted in much, not interpreted, worked with in much the same way that you would work with a dream. A patient has a dream when they're at home in bed, but it's part of their analysis. They bring it to you. And in the very same way, when a patient like this takes a psychedelic, the analyst is present with them when they're not in the room, and there's a meaning in the treatment of the use of those substances. Much like a dream, the fantastical experiences that were had during the psychedelic experience can be worked with and interpreted, and in particular, worked with in their transference meaning. And the paranoia transforming to metanoia, if I'm understanding correctly, is a beautiful example of how a terrifying experience can be transformed by being held, cared about, listened to, interpreted in an analytic setting. And this can even occur when the paranoid traits or the paranoid position is directed towards the analyst. By bearing this, by holding this, and being other than the paranoid object, a metanoic transformation can occur in which the patient, trusting, caring presence of the analyst provides a corrective emotional experience in which the paranoia is seen to be not accurate with the analyst at that time. And so holding these experiences as they're reported can be part of a transformational experience in which the dangerous, threatening, malevolent other then becomes seen as a more benign, supportive, and containing other. There is I believe, a description of the substance use somehow threatening the container of the analytic work. And I think that this may represent a countertransference position rather than a transference position, meaning the idea that these things that are happening in under the influence of a drug somehow threaten the integrity or the unit or the connection in the analytic work is an idea more of the analyst than of the patient, because the analyst can hold the idea that it is without question related in the same way that we can do a dream interpretation and presume that the material that the patient is talking about during the dream has a transference analog or is a transference derivative, and work with it in that way. I think that the case shows a good demonstration of why a direct experience or a facility with the idea of psychedelic therapy is important for the analyst as well as the patient in order for there to be a felicitous outcome. Because if the substance use is seen as a hiding place or a refuge or something other than transformation in the analysis, then that is a countertransference impediment to the process having a therapeutic outcome altogether. And so, lastly, we need psychoanalysts that are interested in psychedelics to work for years to develop a psychoanalytically informed model for working with psychedelic experience. We don't have that now, and that is in a de facto way going to lead to an alienation by the analyst toward psychedelic experience rather than a sense of invitation to these experiences being as meaningful and as powerful for interpretive work as dream work. Thank you.
Yeah, thank you very much also for your reference to psychoanalytic working with these drugs and we can discuss this later also again. Now we can switch to Andrea Scalabrini. He is a psychotherapist and psychoanalyst in Milan, Italy, and he is currently an assistant professor at the University of Bergamo, Department of Human and Social Sciences. And research focuses on the relationship between psychoanalysis, cognitive science, and neuroscience, and particularly in understanding the sense of self, psychopathology, and the impact of dissociation on the mind-body-brain system. And what I want also to mention is that Andrea Scalabrini is working together with Georg Nordhoff and Clara Mucci also to explore the intersection of psychoanalysis and neuroscience, emphasizing the importance of interdisciplinary exchanges and the potential for a bridge between these two fields. So, Andrea, please.
Thanks, and thanks very much for inviting me, to all the people that invited and organized this wonderful congress, for the very nice presentation as well. So I'm very grateful, because these days I've learned a lot. So I have to say, and first what I appreciated the most from people that are more expert on psychedelics is that you helped us, all of us, I think, in demystifying the use of psychedelics. So that's very important, the demystification. So there is nothing mythological, nothing too transcendental, is a tool, okay? And I also appreciated very much, Jeffrey, your comment on the case, because it's really helped us to understand how the way we make sense of this kind of experience might change the outcome of a psychotherapy or the use of a tool. This is very similar to many prejudices in Jungian analysis. I have a Jungian background. At the beginning, I thought I was invited for the neuroscience, but then someone told me, no, because you're Jungian as well, so you can be the counterpart. So I have a Jungian background. So also in Jung, in the Jung analysis, we have a lot of tools like active imagination of the interpretation of dreams that are pretty different from the Freudian perspective. And sometimes it was misunderstood because it was considered too new age, but it's not new age at all. It's a tool like psychedelics, and it depends on how the analyst makes sense of that experience with the patients. Then I have to thank our colleague Sergio, because he was very brave in bringing this very difficult case that moved you a lot, with a lot of counter-transference feelings, and we all felt the difficulty of working with this patient, yeah, because it's a very difficult patient. I'm obsessed by diagnosis, so another mentor of mine is Otto Kernberg that really teach me how to diagnose and place a person. This person seems to me a very severe narcissistic patient that use also psychedelics in a self-serving manner for a pretending state of mind, instead of looking for real connectedness to be back to the nature. So it seems to me like use that more in a pretending mode way. But then what can be changed is the approach with the therapist on how the therapists make the meaning of that. So, yeah, so I will try just to define a little bit this case in my term. So I worked a lot on the self, and 2-3 things comes up to my mind. I take a lot of notes trying to be organized, but it seems that it's more confused than than anything. So I will say that there was something missed. So what it has been a relational deficit. So that's another thing we learned, can be only healed and cured by a new relation with the usefulness of tools like psychedelics. So we are open for that. But the relation is the most important thing. And we developed a model of self that is, we call the 3-layer model of self, departing from interoceptive. So imagine an onion. So when the self develops, so first the self is not given for granted. So self comes from the interaction, the early interaction with the caregivers. So we all, I guess, agree on that. And so the interaction with the caregiver really helped us to develop a sense of self in psychological and also at the brain level. So we kind of developed this model that departs from interoceptive self, that is the way we regulate our internal states, that is not mental at all, it's pre-narrative, pre-reflective. Then there is the more we expand, we connect, also the network of the brain becomes enlarged, and then we start to not only feel ourselves from the inside, but also to integrate the stimuli from outside. And again, the mother is very important because the mother has an allostatic function to regulate the homeostasis of the self of the child. And only at the end, we have a mental self. That is our narrative identity, our autobiographical memory. So what has been described before is not narrative at all. There is no mental, no symbolic experience. Yeah, and I might say that this guy, Giorgio, he really suffers from a lack of nestedness of this level. So meaning there is no connection between his interoceptive processing with his mental experience of his life, of his self. So that means really lack of communication, and that's, for me, it is what the therapist should try to do, really trying to reconnect with the difficulties of working in transference, counter-transference matrix. And we know another thing. So I wrote with Georg Northoff and all my group a couple of papers. One was on narcissism, and we really saw that a brain area of the brain that is crucial for narcissism is the insula. So I'm sorry that Mark is not here, because Mark spoke a lot of this brainstem and affective consciousness, affective arousal. But that's only part of consciousness. So insula is the crossroads that really connect the brainstem and the affective to the more mental representation that involves more the ventromedial and the DMN part of the brain. So that we know kind of narcissism have a problem with the insula. There is something abnormal working at the insula. In another paper, I also showed that the insula, that less connectivity in the insula with the rest of the brain correlates with the proneness to dissociate. So meaning there is a disconnection between different layers. And in another paper, we also demonstrate the insula in these 3 layers of self. Higher we go to the level, so more we move to the mental, more the insula increase in degree of centrality in the network. Meaning that in the interoceptive network, the insula has a normal role. More we move to the mental, the insula becomes crucial, because it becomes the dot of the network where you need to pass to connect all the information. So that's what I want to emphasize. So I want to emphasize that in this case, we have a narcissistic problem with hypochondriac psychodynamic way to regulate himself, to deal with his identification with the death of the mother, probably the psychic death of the mother, that also is scary for the therapist. That's not easy, and that's why probably you make sense of the psychedelic as a refugee for him, because it seems to me that it comes out of the blue. It's not something that you propose to the patients. It's something that patients brought to the therapy as a symptom, as a manifestation. And another thing I would like to mention. So in all this picture that I try to convey to you, I never spoke of repression. Yeah? Because this repression implies that we are speaking in a higher symbolic term. We already get to the Oedipal phase. In this case, it seems to me that the early relational experience of this guy couldn't allow the self of Giorgio to develop such higher symbolic capacity. This guy is moving on the dissociative function, with dissociation. He's dealing with dissociation. That's why we have disconnection between these 3 layers of self. And yes, I think that's almost all I wanted to tell you. And so please consider to speak of dissociation when we have this kind of difficult case, and not imply that repression is the main defense mechanism for this kind of patient, this kind of guy. Thank you very much.
Yeah, thank you very much also for your comments, Andrea. And now we come to Gabriele Cassullo. And all know you from your last presentation, and please
Yes.
go on. Yeah.
Thank you very much. Thank you, Sergio, for this case that allows us for some thinking together, which is always precious. And I radically agree with all I've heard, particularly about the fact that I think the central thing is the concept of the self here, which, by the way, is also a problem in translation. From Freud to, but also, from English to other languages. In French, it becomes le moi, which is something else from the self or from the ich. I would start from what we have learned from from Professor Mark Solms, that the fundamental of our consciousness comes from the brain stem. That's, they are the basics, and they are connected with the feelings of ourself, how we feel ourselves. And that has to do with feeling present, that has to do with the feeling real, that has to do with the feeling understood, as Sergio said about this patient, with feeling esteemed, which is radically different about what we report about ourselves, which is something more cortical, how we describe ourselves. And I totally agree that these two levels can be split, in which the patient can feel better, but describing himself as not feeling better, which is an imaginary description of the self. It's not how he really feels. And I wonder if this patient can feel his self. And dealing with his use about the drugs, my hypothesis is that this patient uses the drugs in order to inhibit the cortical description of the self and to merge into the bath of affects, of feelings that Solms described, also regarding those children, and this has to do with a momentary unintrusiveness regarding of the concept of guilt. And I take this, or shame about oneself, about the use of those drugs. And I think it's a radical difference when the patient starts to bring that into therapy. He's still the boss, he is in control, he can use when he wants, not when you want. But he tells you, which is, not a psychedelic treatment, because in that case the patient is not the boss, as I understand it. While in this case, the patient is in charge of, the autoerotic stimulating, kind of use of the drug. But it tells you, and they start to be integrated in the treatment. And at some point, may ask you about what you think of that, and that's the point where blame or guilt can intrude the experience of togetherness that it really needs. Are you with him, or do you judge him? Do you confront him? That, I think that's the part when it can become something like what Guss described as a psychedelic treatment, to my mind, when you are with the patient, and in a way you take the responsibility and discharge the patient of the guilt of using them, basically, because it's part of the treatment. It's not their fault. It's not something they have to blame themselves for being toxic people, which is a great part of this report about the self. That's pretty much, I think, what I wanted to do. Thank you.
Yeah, thank you very much for your comments too. Now we are lucky that we have still some time left for a discussion between all of the colleagues on the table. But at first, I think I want to give you just the chance to respond.
I don't have any comments because I agree with. I have only a question. I think that, as Alessandro told, could be very, very difficult to have an experience shared with his patient, and a psychedelic experience. because according to Gabriele, I asked immediately that yes, he needs to be accepted, but no, he needs to be judged without shame. And also we have the problem that LSD and DMA is not legal in Italy. It is not a little problem. And for this, I have only this question, because for with the other comments, I very thank you, because very helpful for me. Thank you very much.
Yeah, is there, perhaps Alessandro, you have been addressed. Do you want to say something to this? Or it would be good that we have a discussion just among. You want to say?
I'm happy to make it.
Yeah. Okay.
You know, I think that there's a prevailing position within psychiatry and in psychoanalysis that substance use is either neutral or detrimental to the individual. And there is no theoretical construction of how substance use or other kinds of activities might be creative and therapeutic and assist the analytic process. There's an underlying sense that I get in most of the comments today that the psychedelic use is in competition with or antithetical to or in opposition to the more highly esteemed analytic transformational environment. And that is the peak of where the transformational process is supposed to occur, and substance use is seen as diluting that or even opposing that or giving a cheap and easy recess from the more difficult work of analytic process. And I think that that position itself is an overarching countertransference inhibition to seeing a potential for creative transformation in a variety of ways. In the same way that running was evoked as an ersatz or phony solution, or a dead-end solution, or not even a solution at all, but a distraction from solving the underlying problem. And that holds the analytic process as the one and only gateway for transformation to occur. And I think that that position is limits the imagination that's capable, that the treatment is capable of holding together.
So this yeah, this question that the use of these drugs are illegal, of course, is central. I would like to remind me an anecdote. When I make my thesis, I use a group discussion among people who has experience of LSD, including me. And one of these persons, he became a friend, told this anecdote. He was walking in Milano after having taken a dose of LSD, and I saw a policeman coming towards him. And the thought, he said, it's not the normal paranoia, just because, you know, I'm using illegal drugs. So, no, the thought was, is coming a strange person with a strange green hat with two little eagles, and he can ask me to show something I have in my pocket that proves that I am identical to myself. You mean the document of identity? And he said, I will start to laughing, and he will arrested me. So this is an example of what I said, parametanoia. No, it's a deep transformation of a normal paranoia in a more deep thought, in something more profound, which is connected with the idea that, as Jacques Lacan says, the identity, the idea of the identity is a violent concept. We are not the same in comparison with half an hour ago. No? Okay, this is an example for.
Yeah, are there other comments? Yeah.
You want to say something? I want to just say something. So another thing that I'm really impressed, because the way I use research is always in a reciprocal informating process with our clinical activities. So we know, thanks to Carl Harris and all the people that did research in psychedelics, that there is really a restructuring of brain connectivity when you use psychedelic. And there are a lot of similarities with meditation, with dreams as well. We recently published a review paper on neuroscience and dreams. So, and I really think that we can consider these tools as an opportunity that the brain itself has to reconstruct, reorganize itself, as well as the self. But with all these activities, with all these tools, to maintain the change, the relationship is the most important thing. So, and how can we make experience of that? So the same is like a dream. So we can have a transformative process through dreams because we have an analyst, we have a context where we can make sense of that. And we can use that as a symbolic activity and symbolic process and retransformation processing for the self. And so that's what I learned during this very wonderful conference. Thanks very much.
Yeah, thank you. You want to say something?
I think just following on from Jeffrey's comments, I think I have an interest in maybe if we were to zoom out the longer history we have in relating to altered or ecstatic states. I suppose most of us in some ways are a product of Judeo-Christian religion and culture, and I think it can be worth just reflecting on how particular behaviors, rights related to altered states, the union with the divine, whatever language we might use, they've historically been gate-kept by institutions of power. And so I think, it's worth thinking about the moral condemnation that can maybe lie in all of us in relation to these states.
And on a similar note, it may be interesting to note that Freud's movement from trance as a healing process and altered states of consciousness as a healing process to an interpretive process of understanding conflict was interceded by his addiction to cocaine and his need to renounce the urge, the drive, and the hunger for that personal transformation. And so moving from the feeling of exploratory safety in trance to it being a dangerous and problematic process for him may have influenced his shift towards interpretation and language and the talking cure rather than the trance-based cure.
Yes, regarding this return to the ocean, to the maternal ocean of a primal state or the paganic state, like the temples. In the Greek temples, you could enter from any kind of direction, while in the church you have just one direction and one God. So this is this concept of oneself, of the identity card, and we have to be oneself, because if we kill someone, that the person that goes to jail is the same person that killed that person. So I would not. I know and I understand that we have a longing for that primal, unintegrated state or polytheistic state, Dionysian state, and we can regress. We can have therapeutic regression, but I would not take away the child with the bathwater of Western individuality and individual responsibility, which comes from that tradition. And as Freud and Moses and monotheism show, that we become oneself in the identification with the Father, and then becoming fathers ourselves and so on. And I would not throw all that away, you know.
Yeah, I think we are almost coming to an end of our round table. I just want to say one impression I have following the discussion. I think this is something we can just discuss after the break all together, which is some stimulating for our thinking as psychoanalysts. I think that is following the discussion is that we have now the possibility to think in new ways of how to deal with the meaning of the use of these substances in the transference. And there is, I think, and to the relationship, I think there can be seen, and it depends very much on the attitude of the analyst also, and whether it's be seen immediately as an attack against the relationship. Yeah, it is, one could see that is a kind of a stereotype that you see it immediately as an attack, but you can also see it, and this was in your comment, Alessandro, as a kind of protection and to work. And so what you say, this is something I think which I personally learn also from this discussion, how much important it is for us as analysts not immediately to just to go to certain stereotypes of our thinking, but to remain open for the question, what does it mean, yeah, for the relationship, for the patient. And this is something which the analyst that we can discuss after the break. Now we have, I thank you all very, very much. I thank you for your just for openness to because I think it's always very, very important, and also it's not so easy to present oneself, yourself with your work, but you did it very well. Thank you very much. And now we have 30 minutes break and then we return. So now I'm happy to introduce our colleagues, Professor Luigi Janiri and Professor Mariana Mazza. They will just present another clinical case. You can have the biography just there, then I will only say some few words. Professor Janiri is specialized in neurology and psychiatry, and he's currently professor of psychiatry and the former director of the psychiatry residency training at the Catholic University in Rome. And he is also a member of the Italian Psychoanalytical Association and the IPA. And he has published a lot of articles and books. You can see it here on the slide. And Professor Mariana Mazza, she's a psychiatrist, psychotherapist, also in Università Cattolica del Sacro Cuore di Roma, and she's also a psychoanalyst of SPI and IPA, and she has also interests in mood disorders, anxiety disorders, sleep disorders, eating disorders, and has also published a lot of articles. And I think we can be very happy to listen to both of you, and I will give you the word. Yeah. Thank you very much. Thank you. Yeah, thank you very much for this also very dense presentation, and for all the questions that you raised and stimulate. We have a question that everybody off the table who wants can give a short comment, and then we will turn to the audience, including also the colleagues on the screen. Is there somebody who wants to comment?
Try to say something. I think there are some similarity between this patient and the other one, and Giorgio, with some differences, no? Because this patient seems to be more more sensitive to the analytic treatment. But also I'm thinking about the feeling of emptiness connected with the isolation in the childhood. And this is an element in which the psychedelics can help, because they enhance the perception, the experience, for example, of the nature. Now you can feel the plants a real living system, at the point that you can feel anxious if you bite an apple, because you feel the apple is still alive. So this kind of experience enlarge, the experience. And also, yesterday Herbert asked what is remain about this experience. I thought, what is remain is the experience of what's Schopenhauer called the veil of Maya. So the idea that our ordinary, non-psychotic perception of the world is just a fiction, and there are other levels of consciousness. This is open, the breathing of your soul, for this kind of people. And there's many other things. I'm talking about the colleague who works with drugs. And what about oxytocin? Did you try oxytocin? I know there is a spray of oxytocin. And they told me if you spray oxytocin, the other people become immediately loved with you.
Yes.
Anyway, I ask myself, it's probably similar to MDMA as an empathic hormone, an hormone who increases the empathy. I don't know, but this. And the last thing that Freud uses cocaine. We forget, we removed this.
So it's paranoid.
No, it's not paranoid. At that time, there was illegal for 10 years. No. I studied. I teach to the students the project of psychology, which is a terrible text. It's clear that it's been written under the effect of cocaine. If you read the letter to Fleece, the first letter is like Snoopy or the Peanuts. He said, "In a night in which my mind is work with, I saw everything. The veils collapsed, and I saw everything." So after the letter later, he said, "No, probably not." At the end, told to Fleece, "Forgive me, eliminate this." It was a maniac state of mind. And they found this text only in the Fleece house because he rejected. So just to consider that in our tradition, it's what Freud would consider today the help of pharma drugs like hallucinogenic drug. I think he would be interested. Anyway.
So some of the thoughts that I have are more psychiatric than psychoanalytic. First, this is a patient who had a deeply entrenched addiction to cocaine and cannabis. And that process, both at a brain and a psychological level, inhibits the capacity for new experience and change and transformation. Secondly, it seems as though he had cocaine-induced mania and psychosis, and probably does not have bipolar disorder, but had a substance-induced manic episode. Both of those have implications for the structure of the patient and what the goals of the treatment are and need to be. This patient also had remarkable conflict-free areas in that he was able to go to school, work, and do well, and his interpersonal problems and need for substances seem to be related to relationships with women and sexuality. All of this character puts him in a place in which he rather remarkably discovered his own addictive problem and vowed to change it. So his intention in using psychedelics was for help in his addictive process. And he used it that way, and fortunately, his analyst was able to support that process and allow him to use the psychedelic in that particular way to help himself. And I think it reveals how important it is to not lump all substances together, as if substance use always means the same thing for an individual, and that all substances mean something that's defensive or evasive of a transformational process. Yeah, so that's it.
You want to say something more?
No, I think I'm finished.
Okay.
Yes. I was thinking that we had a conversation with Martell about the fact that how do you see, that's my question, how do you see the integrated model of intervention? Do we need to have a physician controlling, or can a psychologist, being a psychoanalyst, be the person who, the analyst here needed the physician, if I'm not wrong. Why is that?
This is a case in which a patient with addiction arrives, and we treated him from a double perspective, a pharmacological perspective. It was necessary to him on one side, and psychoanalysis because because he really needed to go deeper into his psychic situation. But I think that in cases in which we have to do pharmacological assisted psychotherapy, I think usually in the dosing phase, it is necessary that a physician, expert also in pharmacology, should assist.
Do you have courses on psychedelics in your
No, not this kind of approach, but also the clinical approach.
Well, we don't have courses for physicians to use psychedelics because they're not legal. And we hopefully will have legal access to psilocybin and MDMA and indications for their use. But I'd like to share
Is that possible to have it also in a psychology training?
I believe that psychologists can be psychedelic therapists, but I think that the prescription of a medication involves an integration of the entire being, taking a medical history, a psychological history. Many people are capable of doing that, but that is a job which we entrust to physicians in our above-ground culture.
I think this is a great power issue. Yeah.
A great power
issue.
Not
scientific.
Yes, and there are many people who believe that physicians are the worst people in the world to be deciding who should take a psychedelic and why. And that the traditional model of psychopharmacology, which is usually about symptom suppression and affective control, is antithetical to the healing ethos of psychedelics, which are like psychoanalysis, about facing dissociated, repressed material from the unconscious in the context of a safe container, and changing through seeing, feeling, and knowing one's darkest, most problematic parts of the self, which is just like psychoanalysis, which is antithetical to most psychiatric models of pharmacological treatment. I think it's also important to not see psychedelics as a drug you prescribe for a disorder, as much as a kind of relationship with an altered state which is going to be held and made meaning with the therapist in the room. It is not a drug treatment. It is a drug-assisted psychotherapy treatment. So the drug is there to assist the process with which we are intensely interested as psychoanalysts. That is internal transformation through honesty of one's darkest, most problematic internal contents. I'd like to share an anecdote about the work that I did in the NYU study on alcohol use disorder, treated with psilocybin-assisted therapy. In brief, all the people came because they were interested in stopping drinking, but had been unable to through 12-step work or other forms of psychotherapy. And what was most transformational for people was the deeply felt sadness, regret, and guilt over the consequences of their addictive behaviors towards their loved ones, and also a deep sadness of their lost ambitions and hopes and dreams as a result of their addiction. So we all know patients who can list all the reasons that they should quit drinking, but they don't feel them deeply enough to motivate change. And so these known the known impact of drinking problematically was the emotional power of it, and the emotional depth of it was very evident to them, and it stayed with them. So harming your family, harming yourself, impairment at work, all of these negative consequences were much more deeply felt through the medicine experiences, leading to a greater sense of change, need for change, and also the psychedelic brought about something which is referred to as self-efficacy, which is only a fancy word for I can do it. And the belief that I can do it is important for any person with an addiction that wants to change, because many people will say, I know I have an addiction and I know I need to change, but I can't. And so this transformation into this increase in self-efficacy, as well as a deeply held truthfulness of the negative consequences, combined to help people stay sober.
Yeah, thank you very much also for this illustration of a transformational process. Once again, yeah?
No, just I remember that I heard that in Holland, in the Netherlands, now there is a 3-month training for psychotherapists to teach how to manage with, and many years ago, when I had the contact with Albert Hoffman, he told me that in Switzerland there was a psycholytische Therapiegesellschaft, but I don't know if it's still active after the climate has changed. Very useful.
Okay, so just have a few brief comments. So again, I would like to point out the self, because I see, of course, there are some similarities between the two cases, but there are also huge differences. Because in one case, we saw how the psychedelics were like self-serving, manipulative, so they didn't really enhance this kind of a connectedness that we are looking for. I remember yesterday, Jeffrey said, we need to free back the brain to the world, and then we need to, maybe I also added, we need to free the world back to the brain. So I guess that's really important. I think in these altered states, that's what we want to achieve. We want to achieve this connectedness. In this case, it worked well. Yeah, so this kind of regression, it really enhanced the capacity of the patients to navigate through the multiple self-states experienced, to speak in Bromberg terms. And I was very curious because from our way also of telling, because we don't know first I think the diagnosis of the patient is different. So I see these patients with more resources than the other. Even if there is some narcissistic spectrum, this one seems healthier for me. So this also is probably due to the early relational trauma, the quality. So there was something good in the self of this patient and his capacity. But from your way of telling us, I also felt that you felt much more contained. You was much more safe in a way you could work with these patients. And so again, my suggestion is emphasize really the level of the self, the capacity to use symbolic activities or to develop symbolic capacities through the work of psychotherapy, and also the feeling of safeness in working with the patients, probably because also you was not only one, you was two, you was in a network, you felt. So just, I don't know if you have any comments on this, on my comments.
Yes, it was very important, also because as it has been outlined, this patient uses and used psychedelics with no rules, no control. It was probably the continuous tentative to fill his voids. He used other drugs, and then he comes to psychedelics. But psychedelics, as you said, helped us, helped our therapy, is helping a lot, because he's a patient with a lot of capacities. It's absolutely true. And the fact that we are working, Luigi and me together, is for me fundamental. And also because I leave the patient to do his experiences, while Luigi is the doctor who tells him to take drugs, don't take so take the psychopharmacological treatment, don't take other drugs. So he has his role. I only listen and then make my comments, but he's free to tell me everything he does and everything he thinks. This is extremely important. And this is what was first I think it's important, because what we have to do, this is a very particular case. It is different from cases in which we try to have a treatment, a psychotherapeutic or psychoanalytic treatment with controlled administration of psychedelics. It's completely different, of course. This was a case that began in a manner and then is having a good, I hope, development. So this is a very particular case. I think that we know that psychedelics may have a lot of side effects. So we have, in the case we can decide the patient, we have to decide the right patient. Not all patients can be submitted to this kind of treatment. Probably this is a patient that has some possibilities. He is, however, a patient with problems of addiction. So, but we know that many psychoactive treatments that we usually use in patients have a lot of side effects. So this is not we can use this and change the right patient at the same way we change the patient to give antidepressants or anxiolytics or antipsychotics and so on. So it's different.
I believe that we are going to find that recommending psychedelics to patients is more akin to recommending yoga or meditation
to a patient. We can suggest it, but if the impulse to go, if the dedication to the process is not there, it's not going to work. The authority of the physician to prescribe a medication and the patient to go to the pharmacy and take it as prescribed is a kind of obedience and a positive transference to the doctor, and doesn't require very much active participation on the patient's part, except to go get the medication from the pharmacy and swallow the pill. Whereas psychedelic work requires motivation, willingness, interest, and a desire to work in that particular way, just like benefiting from yoga or meditation. If you don't want to do meditation and your doctor says to do it and you go, it's not going to do very much for you, and you're not going to find it to be a transformative experience. It's going to be a transference enactment of resistance, of being told what's good for you, and then you have to go do it. So I think that unlike most medications, there needs to be much more collaborative process happening between the patient and the therapist for psychedelic therapy to be successful.
Thank you. Yeah. The question, do you also want to say something, John? Yes?
Thank you. It was a beautifully written up case. I think I'm probably just echoing other people's thoughts. I think for me there is a very clear difference between the earlier case, and you put it very well in stating it was important the patient started using psychedelics in the context of a good enough relationship. That's just very, very clear for me, and I suppose is a lovely kind of illustration in the wild, so to speak, of the research done in our trials in terms of the importance of the relationship. Another key difference, I think, is intention, which again, research has found in naturalistic settings to really positively shape people's experiences. That was, I guess, kind of lacking in the narrative of the first case. And yeah, otherwise I'm just struck by, on listening to this case, it's as if there are layers of containment around the work you're doing and how helpful that was, whether it's the psychopharmacology or the support you were getting from the medical inputs. Whereas just thinking back to the first case, it sounds like there was huge sort of loneliness, isolation within the patient, but also in the analyst. And yeah, it's just really a reflection of how hard the work might be if you're working analytically and with altered states, and what supports to have a thinking third and the value of that. Yeah, and I think I'd also just echo the value of thinking about selfhood. There's a very good book by a philosopher who looks particularly at how notions of the self are perturbed with psychedelics, called Chris Letherby. And yeah, if you're interested, he's a good reference to look up. That's it. Thank you.
Yeah, thank you all. I think, do you want to respond to this? No. No. Okay, otherwise I think then we can open the discussion, and I think that I propose to start with a question from online, because the colleagues online are waiting for a long time, and we also include your presentation, Sergio. And so
before you go, I just want to spell the name that Johnny mentioned, Chris Letherby, Letheby. If you're interested in Letherby, Letheby, if you're interested in philosophy and what psychedelics can teach us about philosophy and vice versa, go to your PEP server or wherever it is you go for psychoanalytic articles. His papers are wonderful, wonderful.
Yeah, thank you for this. Yeah. Now I will start with the question just related also to your case from Mauro Di Lorenzo. He said, I have a question for Dr. Martell and Dr. Guss. How do you explain that a single psychedelic experience may be life-changing and transformative for some, as we heard from the patients of the clinical video yesterday, while some other patients seem to be searching more and more psychedelic experiences, while more or less remaining the same. Maybe just a little more relieved after each experience, as Giorgio maybe. Thanks. Yeah. Yeah.
I mentioned this yesterday, but the people who were in the NYU cancer anxiety study, who are highly symptomatic but were not on an SSRI, were people who were not chronic psychiatric patients. And they had healthier defensive structures and a greater resilience. And they had to have great resilience in order to be so highly symptomatic and not take tranquilizers or antidepressant medications. So that kind of person, I believe, has less oppressive prior processing, less oppressive priors to change. They have less rigidly intense defenses and are primed and ready to feel better. We have so much secondary gain from our symptoms that the process of change is slow and arduous, and the more psychiatrically impaired you are, the more psychoanalytically troubled you are in a psychoanalytic language, the harder it is to change. That's why psychoanalysis takes so long for many people. We have in America, unfortunately, a one and done, one dose is transformative model, which I think is leading an unrealistic set of expectations about what psychedelics can do. And I think that their role in transforming people is very much yet to be understood. People who go to church every week or once a year or never. Why do some people go to church 3 times a week and others go once a year? And who gets more out of it? What is the need for a transformational process that an individual has? Some people come to psychoanalysis and go 6 weeks and they're better. Others come for 16 years and don't get any better, right? So it has so much to do with the person who's coming for help than the institution itself, I believe.
Yeah, I don't think I've got much more to add. That was, nicely put, Jeffrey. I mean, I can only say in my own experience working in trials, very often people will meet eligibility criteria, so they will have a diagnosis of depression or OCD, and there are instances where we're failing to really grasp their underlying character structure, personality difficulties, and that's where people don't do so well. A 6-week treatment with limited psychotherapeutic inputs can open things up, and we don't have the time or capacity to work through it. And I think coming back to the question, there was something about how do you explain to clients, patients of these varying results, which does open up, and I don't have the answers, the thorny question around consent to psychedelic therapy. It can be so transformative, but how do we map out all the variety of responses an individual can have? And there are some quite, I think, thorny bioethical issues there.
Thank you. Now I think I will just switch between the auditorium and here online. Rosa, you are the first.
Okay. Thank you very much for both clinical cases. At the end of these 2 days, speaking about psychedelics treatment, I have a lot of questions in mind. And I would like to ask, as we have here Andrea Scalabrini, I would like to ask more about self-nestedness, so about the process building the self, the dream, and the second one about addiction. I would like to ask you, to all of you, something about addiction. The first question is this. I'm reconsidering something about the self, building the self, the process of self, formation of the self, because of, in the dream, in the minimal form of the dream, when we lost everything, but we just remember something. And this minimal form of dreaming, we always confound the self. This minimal self, I'm I, who is dreaming. The self is always there. And it seems to me, in case of psychedelics assumption, seems to me we have no self, like your joke. We lost ourselves, or maybe we can have one self, multiple self. It's me, it's another one. So I'm pondering about this, Andrea. Are we talking about ego dissolution as dissolution of the narrative self? Okay? And what happened to the other level of extroceptive self and introspective self? Are we sure we can talk here about dissociation? Or maybe we can talk about dissolution of this boundary between self, different level of the self. You know, I think this is the stratification of the self. We cannot talk about multiple self. This is the first question. The second question, follow view, is about addiction. Are we sure we are talking about addiction in these two cases, or in general, generally speaking? Because the craving, the dependence, the behavior, addicted behavior, all these behaviors go on other circuits, the addiction circuits. The addiction circuits is totally different from what we are talking about. So I don't think we are talking about addiction. We are talking about something else.
Taking notes. Thanks, Rosa. Wow. So that's huge questions. I mean,
two of them.
Yeah, I mean, two of them, right. I mean, it's not easy to answer this because we don't really know much so far. So, nestedness of self. Okay, that's also very, very difficult, but you give us the chance to better explain it. So, instead of departing from the mental self, let's depart from the origin of the self. So, as I said, the self, for me, at least for us, people that work on the field of the self, is not given for granted. So, and the synchrony that was also emphasized by Francesco yesterday is really key. So there is a very interesting, wonderful researcher. She's called Ruth Feldman, and she does a lot of neuroscience and developmental health and psychopathology for the children, the mother-infant interaction, and so far. So, and she suggests, so there are two people, right? There's Ruth Feldman and then there is Feldman Barrett. They both different place, but they work on similar things. So they really emphasize, and they're really close with us in the psychoanalytic societies, because they really emphasize on the role of the caregiver in the formation of the self. They both see the insula as a key hub, because the capacity of regulating the system, the whole self-system of the mother can be transferred to the capacity of the children. So allostasis to homeostasis. And also there is a very nice paper of one of our PhD or postdoc students published in a very high-level journal where they show that synchrony at different levels, it's really key in the development of the self. Meaning the biobehavioral synchrony, the endocrine fit, the heart rate synchrony, and the interbrain synchrony. So it's wonderful. It's really a wonderful, wonderful paper. So this, for me, is necessary for the development of the self. Okay? When I speak about nestedness, so it's the capacity of the mother or the therapist. Okay? So we can compare that can enhance the nestedness and the integration between the different layers. So nested goes with integration. So a good self, a good enough self, is a self where the interoceptive stimuli and the interoceptive network is well connected with all the other layers. So it's enhanced, okay? It's expanded, not only in psychical terms, but also at the brain network terms, okay? So we have a brain network that is deputed to process interoceptive stimuli that can be expanded to the exteroproprioceptive and the mental one. So in previous papers, I tried to correlate these three different layers with more psychodynamic terms. So if there is a problem in the interoceptive capacity to integrate internal stimuli from the body, probably a huge lack of mirroring or something that's patient lack, probably you are moving towards a psychotic organization of personality. If the problem is inter or exteroproprioceptive, out-of-body experience, the realization, so maybe we are in the dissociative spectrum or maybe borderline organization level. If we have a problem in our mental self, we are probably dealing with conflicts. So we are probably more in the neurotic spectrum, yeah? So that's, for me, it's important to have these things in mind, because that's also what I wanted to ask. So we really maybe we need a guideline to understand to which kind of patients we can deliver psychedelics, according also to the level of their self-resilience, self-capacities, self-organization. Then you asked another thing that's super complex, because you asked the difference between altered states from psychedelics, from the dream state. So in the end, before you said, Andrea, maybe the agency is the key. So I have the feeling that I don't know, okay? So I don't know, so I can only give you my impression. So probably in one case, in psychedelics, but then I look into Jeffrey and to other people, you really have this kind of connectedness with the world that is enhanced. Okay, so it's like you really have this kind of out-of-body experience. So you, maybe for the first time in your life, where you have this possibility to feel as a whole unity. And probably non-duality is more emphasized. The more non-duality experience, phenomenological experience, is more emphasized in psychedelic experience, psychedelic altered minds. In dreams, I don't think it's the same. You still have kind of you're more grounded to the body, more grounded to the self, to your own, I would say, core self. In the other case, I feel it's more kind of transcendental phenomena that detach yourself from also your whole automatism, your internal working models, what you learned from your traumatic experiences. So in a way, I think that the psychedelics have much more power than the dreams in this case. I don't know if I answered, but that's. You agree? Do you agree? Okay, so if you agree, we are happy if you agree. So you are the boss here. Thanks.
Yeah, thank you. I think we go on with the question. Perhaps once again to the online question as to Jeff, is it possible that electroconvulsive therapy as a kind of heart-brain reset may be somewhat analogous to the use of psychedelic-assisted therapy, where psychedelics induce psychosis as the process of dreams as a soft brain reset?
No. No, I don't think so. I mean, I haven't spoken with many people who have had ECT, but it was early in my training that I had it, but people had complete amnesia for the experience, and in fact they were pre-medicated in order to have complete amnesia, and they also suffered from memory loss for a transient period of time. And so both of these are antithetical to the psychedelic experience. I would like to answer Rosa's question, and I was very glad to hear you describe ego dissolution as dissolution of the narrative self, which is the personality, which is the sum of our defenses, which is our adaptive personality for functioning in the world. That is what is dissolved in ego dissolution, and what remains when that is shut down, is quite profound and is the stuff of dreams and religion and mystical experiences throughout time and throughout and all around the world. I think it is one of the most fascinating conundra of, to me, of how it is that someone can say, myself was gone, my narrative identity was obliterated, and yet have memory of that experience, and yet be able to get up and go to the bathroom, and then come back and re-enter that state. So not all ego functions are dissolved. That would be a disaster. So it is the narrative function that worries about the future and has regret about the past, that we generate defenses in order to organize an adaptive personality to survive and to live. And what is experienced in an ideal psychedelic state is the intense presence in the present moment, which is about the sensual information coming up from the body and coming from the outside world. And of course, the body, inside the body and outside together, is everything. So there's an intense presence in what is happening at this very moment to the me that is not being clouded by defenses that want to keep information out. And that's sometimes called by Winnicott, I believe, the true self, the authentic self, the spontaneous gesture. There are so many different terms that we use in psychoanalysis for who we are when our defenses are softened or are gone. And it is spending some time in this state that is so intensely memorable, partly because of the affect of awe and sometimes bliss or sometimes terror, followed by bliss or comfort, at least, all of which, for which there is memory. This is an important part of the psychedelic experience. You are there for your not being there, which is such a paradoxical thing. It's hard to imagine if you haven't experienced it. But people will say, who I am, I cease to exist. And they were there to be in that and remember it.
One could think of whether this is also describes the transformation in O, according to Bion. Yeah. But Misha, yes, I have you and you. Yes, you.
Maybe I will disturb a little bit the mood of the complete audience. I miss something. I feel the tendency to have many, many levels of multidisciplinary descriptions of whatever, including brain and insula and whatever. And even if you touch the question of mystical experience and being still aware, I missed it in the clinical case. It was only a short vignette. And the process, what these persons have experienced on the rock, it was only 2 or 3 sentences or 4, also in your case. And if I would be, let's pretend I'm a stranger coming to this conference about altered state, including Mark Solm's description about networks of brain function, and including institutional hustle between medical and psychology stuff, using medicaments and all this. I miss the description of what was really touching in people who experience this. It's not enough to say, sorry, peak experience, of course. What is peak experience? It's like talking to someone about orgasm and someone has not experienced it. It's just an empty capsula. So there's something I miss in the clinical case. I have to say it to you personally and also to the other person. It's a fine clinical description and you make all your thoughts about it, but I missed the existence of the unique situation. What was the psychedelic experience of this person? It was not just 1 or 2 sentences. That's not life-changing, for sure not. and all the people I have experienced, including myself, and if they find words again after 5 or 6 or 40 hours, depending on what kind of stuff you are taking, then of course it's a question how to transform this. And so I have to admit, even now I'm not making an additional, so I'm still in the same framework. I just want to use at the end the word beyond. It seems to be difficult to really touch the state beyond our normal state and to find, maybe it's the need for music and poems and something like this, but it's so sterile in between to listen to all you. You're very, very great in doing your specific job and being careful and all about this. It's not a question about, but in an emotional sense, I miss something. I just want to transport this to you.
Yeah, thank you for this impression, Michael. I don't know, shall we take this as an impression, or do you want to say something to this?
I don't know if I understood well the fact that you say something missing at the emotional level, so you didn't feel what this case, the case we described.
It's if someone has really a peak experience, not only, I found it funny what you mentioned with the Milano story and the police stuff. That's only a very, very short particle of a situation beyond. That's a funny story. But if a person is really deep inside touched with something, and it's difficult to find words about this, that's much more intense. And I expected something more, because this could be also a description of, let's say, a normal psychotherapy or normal dream description. I missed the difference. I missed the altered state in the description. I didn't get it.
I can say, talking about the case of Francesco, that what I have seen, what he is learning, what I'm learning from him is the fact that in my opinion, he began to assume drugs since he was very young, an adolescent, because he was searching from a true self. He had an identity problem. He had some traumatic experiences, okay? And the experience with me during therapy, when he took cocaine, for example, he came to me and wasn't able to even say anything. He was without thoughts, without, sometimes he didn't want to talk to me, and it was very frustrating for me. When he began to take psychedelics, he came and was sometimes in a dreaming-like state. So he began to talk about him, to reflect about him, and I felt a great difference before and after. These were my emotional involvement in this case. So I understood that a drug can enhance this capacity. For Francesco, I'm talking about my patient.
If it would be my patient, I would like to explore what did you experience during your psychedelic time of 4 or 6 hours. Tell me about it.
Yes, yes. It's not simple for him to tell everything about this experience, but he's trying to do this.
Perhaps we can leave it.
I'd like to add, perhaps that what you,
if I just can give you my impressions on the clinical side of the patient, and because I think that this patient underwent a kind of shifting from a situation. This is also a way of answering the question of Rosa, that I thank you for your interesting, puzzling question, because he was shifting from a clinical state of really addiction and dependence in the sense that cocaine, for example, was functional to him to relieve depression, anxiety, and symptoms on a, we would say, a self level, maybe narrative, but anyway, on a superficial level. When he shifted to using psilocybin or LSD better, he was not so addicted to substances, in the sense also that these substances are not able to give physical dependence, for example, or anyway dependence. There was some craving, yes, okay, but the level of dependence was different, and he seemed to use substances as a self-medication for some deeper level of his functioning. So something like a self-medication against symptom medication. You not agree?
What I think that you're
just in a short way, you're describing again something which I call the psychiatric level of describing to change the function of one drug to the other. But if someone is doing LSD, he will be 12 hours or even more tripping. And there he will make an experience. And I suggest that most probably this guy has a story to tell if there's a good environment and to take it in. And so that's what I just exactly miss. I am interested, what has this guy experienced?
What I think you're looking for
you're speaking on the level of changing one stuff to the other.
Right. Love. What you're looking for is love, connection, awe, the mystical state, this profound feeling of connection, love, being understood, being safe, and that is the primal healing force in the universe, in my opinion. Love for yourself, love family, love for the planet, and the feeling of safety and love and bliss and awe that can be remembered and that can emerge in a psychedelic state. And that is what's healing. Is that what you're feeling is missing? Yeah.
I think there is something more which is, I think, very interesting. He's suggesting that the patient should rebuild a new narrative self. No, he's asking for the narrative of the experience. Therefore, the cortex is again there.
It's affective.
Excuse me?
It's an affect.
I know, but on après coup, after, you are rebuilding the experience of yourself. Your narrative experience, which has been dissolved, is rebuilding. You are narrating where you were and what you were doing, not just the bath, the affective bath that you described, the primary love, but then I tell you what it is like.
May I say, I think we have to stop this here, but I think it's a difficulty of expressing the affective states, and this is the question of our language. We in this realm we can only have the possibility to name some of this. The other, what you are looking for, I think, is a kind of a feeling. But this is something different. Yeah. But I think just in order to go on, I think now you are the next one. Yes. Please, you can introduce yourself.
Sorry?
Please, could you introduce yourself?
My name is Franco. I'm a psychologist and I work in the public mental health service in Tuscany. And the question is about set. As we have heard, set and settings are very important in psychedelic treatment. Okay, so my question is about Francesco's set, about why psychedelics could help me in stay away from coke and cannabis. I mean, he started using psychedelics to stop cocaine cannabis. Am I right? Okay. I would like to know what were their beliefs, their expectations on why these psychedelics could help in stop cocaine cannabis. This is a question about the set, Francesco's set, and the other is more than a consideration than a question, and it's that maybe we have to think not which substance for which psychopathology, but which substance for which patient in which moment of the process, of the therapeutic process, for which pathology. So indications and contraindications, we have to deepen this, as most of you have said. Okay, thank you.
But the switch from cocaine and addictive producing substances, cocaine, particularly cocaine, but also MDMA, ecstasy in the same period, I think really was functional to a particular moment and the state of the existence of Francesco. Francesco, because you know that in the description of the case is obviously was very short in description. So many events and many situations in his life were changing then, and for him, at a certain point of his affective life, working life, professional life, and his interests were changing at a certain point. And this change was accompanied, was associated with a change, with a shift in the using substances from one type of substance to another type of substance. I agree about the fact that we have to consider the moment, that patient, and not starting from substances, because we have just to make a general consideration, discussion about substances, but we have also to merge into the particularity of the patient, of that patient in that moment. So it was a turning point in his existence that was marked or signaled by the change of the shift of the substance.
Now, I'm afraid that we cannot accept all questions anymore, but I think that perhaps one you will come next one. But first, there is one question also related to your presentation, Sergio, but perhaps it's very clear that because the question is if the patient strongly believes, the patient of Sergio, that he had a fatal brain cancer and cannot be cured, then why he's coming to therapy? I think one could say he nevertheless had a kind of hope. Or what would you say? Anything? Yeah. 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 Okay. So you perhaps give the micro.
Yes, I wrote on my paper. He asked therapy because the lockdown. During the lockdown, he felt very claustrophobic feelings, anguish. He was afraid about his angry. His rage. Only for that.
Thank you. Now I think I will read another question from the chat and also then ask you to bring your comment and then you can answer this. The first question here is the question, is it possible to think about the use of empathogens like MDMA in patients with callous unemotional traits or those who have a lack of empathy in general? So, yeah. So this is the question I keep it. And now, you, yeah.
Thank you. This is a general comment question. I believe a lot of colleagues from different disciplines that are present here might share this question, hopefully. Where do we go from here? In the sense that I think Dr. Martell's groundbreaking work raises the question, the impending question, once the ground has been broken in, so to speak, will psychoanalysts stay passive in front of the tendency that has been talked about of psychedelic therapy having a tendency to be reduced in costs, maybe reducing the psychotherapy, or maybe even eliminating psychotherapy altogether? Or always, how can the work of individual psychoanalysts that have already worked in psychedelic assisted psychotherapy, like the work of Dr. Guss, for example, how can those individual efforts congeal in a more active, communal, international effort by the psychoanalytic community? This initiative, this meeting is a great initiative, but the question remains, where could we go here? That, in your opinions.
Just thank you very much. Can I just add perhaps, and then we have also a question, we have another question which was to my mind already answered during the discussion, whether the patient's personality structure is taken into account or not during psychotherapy with psychedelics. I think this has already been answered. But here's another question in Italian. I can just read it. Sono in uno stato alterato per questo convegno. Apporto la mia considerazione del fatto che non si parli di stati modificati irreversibili dal cervello per le droghe, la impotenza che i pazienti drogodipendenti fa sentire, passiamo a sentirsi potente con l'uso di psicodelici. E peraltro può essere considerata psicodelica l'uso della ostia consacrata. Perhaps you can translate it.
So is asking if if I understood well. I mean, if the use of psychedelic can be considered as a power tool, like the ostia. I don't know how to translate the ostia. The holy bread in church. So psychedelics can be considered as a power.
The churches of South America.
No, this is very funny because many years ago I was working with heroin addicts in a public health center, and I read a paper in the Civiltà Cattolica, the review of the Jesuits, and a very clever Jesuit compare the use of heroin with the Eucharistia, and you think that it's unbelievable. You think about the name of the peyotl is Theonakatl, which means meat of God. So the idea that you eat something that help you to become like God, it's a very interesting idea. Huh?
Well, I'd like to suggest that perhaps our first psychedelic is nursing, in which a substance and love together are a transformative experience and a life-saving experience, a life-giving experience. So our first experience is one of substance and spirit together that gives us life and sustains us life and allows us to transform. On the other hand, in addition, I'd like to say that the use of psychedelics as treatments for psychiatric disorders and in psychoanalytic treatment is peripheral. It is not the central way that these substances have been used in cultures for millennia all around the world. They are part of religious sacraments. They're used in groups. led by a shaman or some kind of, authoritative leader for a relationship with God, community, cosmos, our ancestors, and connection. And so this transformational experience with all that is in a religious setting is the more normative place for psychedelics. And we've taken them and are using them in our very own special Western way. And I think we have to have a lot of respect for where they came from, and not insist that we fit them into our way without knowing their origins and what they have to teach us about their use.
Did you want to say something onto this, Claudia, a short, very short, yeah. And then.
I want to go back to the intervention of the Toscan colleague and to relate to the clinical case by Marianna. The question was about the switching from cocaine to psychedelics, as far as I understood. And I would like to go to the contemporary approach, a psychoanalytic approach to addiction. And there is, according, for example, to Zuzman, this shift from addiction to dependency. In Italian, unfortunately, we have only one word, which is dipendenza. But in English, we have addiction and dependency. And probably in your treatment, you did a good job, and the patient probably could be able to rely on you and to leave the addiction and to switch to a dependency in the relationship. And this is probably why he would lose the dependency from cocaine and to try some self-medication and some more new experiences with psychedelics. I think so. You did a good job, and thank you very much for the case.
We have reached our time limit, except when it's a very, very short question, then I think, because we start a little bit later, but really very brief.
Thank you. Good morning. My name is Raimondo Tarantino. And in reality, I would like to have some comments from you, because I'm trying to make as kind of I try to put together the puzzle, the pieces of the puzzle of this conference. Okay, in the beginning we started to say that there are two different kinds of states, the Apollinian one and the Dionysian one. Okay.
It's not a long comment, please.
No, I'm sorry. I'm sorry. But, very short. In the Apollinian, there is a differentiation between the ego and no ego. In the Dionysian one, there is the fusion and the sense of the fusion that we have inside the reality. And maybe this kind of state is the state that we have in altered state with psychedelics. Okay? With psychedelics, we can compare the psychedelic states with a kind of psychotic state and a kind of ecstasy state. Okay? And the difference between the ecstasy and psychotic is how we interpret, the interpretation that we make of our sense of our perception. In the ecstasy, we feel pleasure. In the psychotic state, we feel a kind of fragmented reality that is inside, a kind of anxiety of fragmented reality. Okay, so in order to the most important thing is the interpretation that we have of the state we are perceiving in that moment that we are perceiving the state, that particular state. So the importance of the psychotherapy is very important for the psychotherapist is very important for let the person and the patient to perceive in a very good way this kind of different state of mind. Okay, so I would like only to know your comment if this point of view that I have in my mind is right,
that the interpretation is the crucial point of these phenomena that we perceive. Only this I would like to have.
Perhaps we can take this, because I think we have reached our time limit, and I think what you said relates also, I think, to what I wanted to say, because it was my task to give some concluding remarks. And they were allocated 30 minutes, but I cannot speak 30 minutes because you are all tired and we have heard a lot. Perhaps, but I can take this because I had similar thoughts, just for to have a reflection about the whole conference, which I personally appreciate very, very much. When starting especially from this mentioning of the Apollonian and Dionysian sphere, I think it was very clear that during the conference we learned, we know it before, but now it was more intensified, that the Dionysian aspect is very important, yeah, and that which relates to my mind also to what Mark Solms has brought to us, the importance of the affective, of the feelings, yeah, that what is conscious, also from a neurobiological point of view, is not so much in the cortex, but is much more in the brainstem. So I remember, and I want to remind you on his excellent lecture. And this, I think there is a connection between the Dionysian and also the affective. But what we learned, and especially from a psychological point of view, is that this cannot be done, according to our understanding, I think, just in a state without any relatedness. I think, and this is perhaps also what you meant. So we need to embed these experiences, and this was very clearly said also by Jean Martell, in a relationship, and that the idea that the drug itself would just be effective, I think is not enough. A short vignette from my experiences. I had a transgender adolescent patient, 16 years old. It was a transition from male to female, and this adolescent, similar to your patient, used psilocybin outside the sessions. Yeah? So, sorry. Also, in order to declare that it would broaden her mind and her experiences, and she was very often explaining this to me. And one day she did this together with her boyfriend, together in a room, and being both together using psilocybin caused a severe psychotic breakdown. So, and this is, and this was I mention this because it was outside the therapeutic realm. Yeah, and so I want, just to, from my point of view, I want to underline that whenever these substances come into use, I think it's very important that there is a therapeutic psychoanalytic frame. So then I want to remind the question which was also raised by Mark Solms, which we all discussed in several levels, whether it's really possible to reach with the use of hallucinatory substances these procedural layers and the non-declarative layers of the brain. And so this is something I think which remains as an open question. And I'm sorry. The question about the narrative self, I think, relates also to this question. I think we very much agree on the fact that it's possible, and you in your clinical presentations and also in your theoretical aspects just helped us to learn more about this, that it's possible to change some narratives about the own feeling of the world and of the own self. But it's very important to bring this in a new kind of interpersonal, now I'm again talking about my impression, yeah, to bring it in another interpersonal new experience which is affective laden but also connected to language. So this there we have a kind of a more effective narrative self. Could be one of the ideas. I personally, I'm reminded it's not the same, but I want to mention this shortly, briefly. There is a German psychoanalyst, his name was Alfred Lorenzer, and he has, it was in the 80s of the last century, he has had a concept that he called, I say it first in German, it was Sprachzerstörung und Rekonstruktion. It means destruction of language and reconstruction. And his main concept was that those who are suffering from several symptoms have a kind of distorted meaning of language, by which the meaning includes also affective meaning. Yeah? And the task of the analyst via transference and countertransference is to also in a way to break up the distorted meaning, and via the transference to have new experiences, to reconstruct the language, where the language is also an affective language, which now denominates also the relationships. And I was reminded whether one could perhaps, this is just the first idea, yeah, but whether one could think of similar models for the meaning of psychedelic assisted psychotherapy, whether this also could help to find a kind of reconstructed language which is more to the true self, yeah, or so in the presence. I also think it's very important that is needed to have present experiences. So I think but there are a lot of open questions, but I'm very grateful. I think we can be very grateful to all of you who have presented, all of you who have raised your questions, that we will go from this conference with a lot of enrichment. Thank you for the organizers. You have made a wonderful conference.